Mr. Scott.
Good morning, my lady. May we please call Julia Jones?
I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
nothing but the truth.
Good morning, Mrs. Jones. You're here today to give evidence on behalf of John's campaign. Is that correct?
Yes, indeed, and I'm part of a co-participant group which includes the Patients Association and Care Rights UK.
And we have a joint statement which is signed by yourself and then two senior members of Care Rights UK and the Patients Association. And can I just get a little bit of background just about your organisation? Because I think you'll believe you are the co-founder of John's campaign. Is that right?
Yes, I am indeed.
And John's campaign came about as a result of an individual's who you phrase it as the observed deterioration and death of a man living with dementia when he was separated from his family support due to infection control measures taken in hospital. Is that correct?
It was almost like a microcosm of what's happened now, yes.
And the point of John's campaign is about supporting vulnerable people and their families where a person in need of support is being accommodated in any of the institutions of the UK. And in particular, there's a campaign for a legal right to a personal care supporter in respect of each individual rather than in respect of any health or social care institution. Is that right?
Yes.
And John's campaign, do you hear just from patients or do you hear from healthcare workers as well?
John's campaign wouldn't function if it weren't for the goodwill and the understanding of people working in health and care settings. So, yes, of course, we lobby, particularly for people living with dementia. That's where we started, and for their family carers. But John's campaign has no organisation apart from the goodwill of people working in hospitals, mental health units, care homes, any of the health and social care institutions.
When was John's campaign founded?
10 years ago.
And just in terms of then the Patients Association as well, I think a fair summary is that the Patients Association, it seeks to provide the patient's voice in relation to the treatment that they receive in healthcare. Is that right?
Yes, and I know that the CEO of the Patients Association is with us today, and she feels passionately about the patient's voice, but also about patient partnership.
We'll come back to the patient partnership. But if I can please take you to, I think, what's the central element of your statement. If we can have up on screen INQ 000 283 597, 957, and it's page 18, and this is paragraph 41. It sets out there that as a core participant group, we have been and continue to be particularly concerned about the intense focus on infection control at the expense of many other healthcare issues faced by individuals we represent. So that had a huge impact on the quality of overall experience of care for those who required it, significantly impacted the quality of end-of-life period and death. Can you please expand a little bit about what you mean by that paragraph in terms of where the balance lies between infection control in a pandemic and the other aspects of healthcare that you believe there should have been more prominence put on?
When I said that our experience with Dr. Gerard, after whom John's campaign is named, was like a microcosm of what's happened between 2020 and 2022, it was because he was a man living with dementia, living well with dementia, who was taken into hospital for a fairly minor procedure. But there was a norovirus outbreak in the ward, and the default mode then of infection control was separation and isolation, no visitors, slam the ward door. And my co-founder, Nicky Gerard's family, had no idea what this would do to her father. He simply lost all his, he lost his body weight, his power of speech, his continence, his mobility, because he'd been sundered from that framework that had been enabling him to live well with his condition. And we've learnt since then, and I know others of your witnesses have said this doesn't just apply to people who are living with dementia. It applies to so many people who need that additional carer support. If the main method of infection control is separation and isolation, the damage and the danger is far greater than dementia is incurable. You can survive COVID, you don't survive dementia. And that was a known fact, and we were deeply shocked that that wasn't considered when the infection control guidance was set up. Eventually, there were some exceptions to the guidance, and they were very welcome. But it made us wonder whether the infection prevention and control cell, as it were, had actually consulted with people outside of that cell, whether they had actually consulted with patients. One of your witnesses, I think it was Professor Gould, said that she felt that patients and their families should have been part of the infection prevention and control guidance because they're the ones who are going to have it done to them, I think is the way she put it. So it made us wonder whether people issuing that sort of guidance are sort of aware of the diversity of people and the diversity of needs, and whether they're obliged to take that into account when they're drawing up these sorts of guidance.
Can I just to clarify, you're not saying that infection prevention control measures are bad,
Of course
per
not.
se. You're just saying that the balance in certain situations was wrongly drawn. Is that a fair summary?
It's one of those situations where the prevention could be worse than the disease for some people. My co-founder, Nikki Gerard, went on television on March the 13th, 2020, and said for people living with dementia, separation and isolation will be worse risk than COVID, and that has proved to be true.
Do you think that there should be a different approach taken in pandemic times compared to non-pandemic times? In relation
Yes, of course. And that's where one needs to look at the difference between visiting and caring. So I think one would, of course, want to reduce footfall in health and social care institutions, and people themselves would wish this to be the case. People don't want to go bringing infection into hospitals or indeed acquiring infections in hospitals. But if you know that the outcome for the person who you care about, who you support, is going to be dire without you, that's where there needs to be flexibility. Flexibility and conversations. Infection prevention and control needed to be much more complex and nuanced and appropriate for individual need, in our view.
And what would that have looked like? How would that flexibility have presented itself in a way that you thought would have been where the appropriate balance had been drawn? And I appreciate it's very difficult to generalise at different stages of the pandemic and different settings, but if you're able, as far as possible, to give examples of how you think things could be done better.
Well, in the very early stages, there was a complete visiting ban, but immediately there were exceptions to the ban made for parents of children, for people who are dying, and for women who are giving birth. And in Scotland, very quickly, people living with dementia, learning disability, or other cognitive impairment, where separation caused distress, there was an exception made for them. In England, that did come. It came on April the 8th from NHS England. Unfortunately, by that time, the very negative message had gone out.
Could you just tell us what that negative message is?
Yeah, the negative message was shut your doors. And of course, I also think that as the pandemic continued, two things, and what I'm talking about is also relevant to Northern Ireland and to Wales. It's not just England. As the pandemic continued, there were sort of fluctuations and changes to guidance, which unfortunately got people quite confused. And so I think there was a lack of psychological insight in that when you've sent out such a very negative message to start with, and where people are very frightened, and where you're looking at death statistics every night, so many people took no notice of all the nuances and the iterations of guidance, particularly when it became locally, you could make your own minds up locally, which should have been a good idea, but actually wasn't.
Picking up that thread then, why wasn't it a good idea? Was it because of confusion that it caused? Was it because of difficulties in applying that? What do you think was the problem with that kind of setup?
Well, we became very aware of variability between particularly the English trusts, but actually I think when you were speaking to Professor McArdle, it was very obvious there was variability between the Northern Ireland boards as well. But some hospitals would listen and take the guidance and have an overall flexible attitude that if the patient needed somebody and it was essential to their health, then the essential person would be welcomed, whereas other hospitals would say no. And it could go down to a really micro level. I had a very distressing incident in one of the hospitals I would have thought was one of our best John's Campaign hospitals, one of the hospitals who had really taken on the idea of patient-centred visiting. But there was a gentleman, and he was non-English speaking, elderly, and he had living with dementia, being cared for by his son and daughter-in-law, was taken in to a hospital with no provision made for the fact that he didn't speak English. And he got to the end-of-life state, and they were now no contact, no support at all. He was moved then into a different ward in the same hospital for his end-of-life care. And the nurse said to him, "But we're a John's Campaign hospital. He has dementia. You could have been coming in all through this time." Think how those people felt. And of course, in that case, he did revive. He did start to eat, which he hadn't been able to eat before. But sadly, it was too late, and they kept him better for a week or so, and then he died.
Where do you think the flexibility in guidance should be built in? And it could be at more than one level. Should it be those who are creating the guidance? Should it be at regional level, trust level, board level, or ward level? Where do you think is the best place for that flexibility to be built in, given your experiences of assisting people?
Well, actually, I think I'm not sure flexibility is entirely the right word, because what I actually think is that we have very good laws in this country, such as the Equality Act, such as the Mental Capacity Act, and indeed such as the human rights legislation. And I think if those pieces of legislation, particularly the Equality Act, had been better observed, then I think guidance would have been drawn up that was in accordance with legislation. And yes, flexibility then does come in, as Ms. O'Sullivan was saying yesterday, people with learning disability, for instance, who should have reasonable adjustments made for them under the Equality Act, not just because somebody's feeling kind, but because that is their legal right, then those people would have been better catered for.
And do you think that those who are, so sisters, other people who are working on wards, do you think they would have been assisted by a better rights-based guidance being given to them about when people could visit it and the circumstances to which visiting should be allowed?
I do. And I think obviously it's also a communication issue. I think there's a huge amount that could have been done to reassure and support ward sisters, ward managers, or the managers of mental health units or anywhere in the health and care system, that actually it was okay to say yes carefully, say yes in consultation, but otherwise it felt that the default option was just say no, and that wasn't best for patients.
Do you think there was a sufficient, and this may be a question, but also for the Patients Association's view on, do you think there was a sufficient patient's voice being put into the creation and the changing of guidance as it went along?
No, I don't. And I think that the Patients Association would, I think as I've already said, have recommended that the patient voice should have been there in the drafting of guidance. But I also think if you look within hospital trusts, for instance, they have patient experience departments. And I ask myself, were those patient experience departments well used during the pandemic? And I think, as with so many things, the answer will be in some cases yes, but in other cases no.
How do you think they were best used?
I think they would have been very well used as a clear point of communication, that if somebody was anxious about that they felt that their relative needed this additional support, and they felt perhaps they were aware of the guidance, perhaps they knew they should be entitled to it. It's very hard when you're a person in the community looking at a big institution like a hospital. You don't know who to ask. So if the patient experience departments were there, it would be a very good point of contact for families to say, I really think that my mother needs me in hospital, or we're really distressed that we've been told that our sister is on an end-of-life pathway, but we're not being allowed in to see her. In fact, what very often happened was if they were savvy enough to know about John's campaign, they might ring me up, and I might find I did know somebody in the hospital, and I could ring them, perhaps a lead dementia nurse, or perhaps I would need to go to safeguarding or the director of nursing, and I would go to somebody in authority. I say, look, this is happening in your hospital, and they would say, oh dear, no, that's not our policy at all. And so then they would go to ward level and say, actually, you should let this person in, it's part of our policy. There was a huge gap between what happened at the top and what was written down in guidance, but what was actually happening among very frightened people under stress and taking large and scary responsibilities.
It sounds like you had a number of those conversations. Is that gap between the top and those applying the guidance, was that a very common theme that you found?
Yes, and the sad thing is that, of course, only the people who were assured enough to, somebody told them about John's campaign, or they found us in sort of desperation trawling the internet or on social media, those people could get through to me or to Nikki. But people who weren't confident and didn't go on social media and didn't use the internet, there were so many people who must just have taken their dismissal, and they'll be nursing the hurt until this day.
And it shouldn't have been just because people made contact with you. It should have been available to everybody. I think you'd probably agree with that.
The experience of the pandemic changed us enormously. We used to believe that you could get things done by relying on people's goodness and their wish to do the right thing. And in so many occasions, that's absolutely true. But we now feel that the power imbalance between patients and their families and the institutions of health and social care is so great that we now feel that there should be a legal right lying with a patient, that if you're a patient or a service user or a resident and you need this personal support, you should have a legal right to have it.
Just a couple of things. You said we on a couple of occasions. So who do you mean by we?
So firstly, I meant Nikki and I, who changed our views. Then, during the course of the pandemic, we worked with other organisations, principally to start with other dementia organisations. But then we came closer to Care Rights UK and to many care organisations and health organisations. And I can now say, possibly it's out of the scope of this inquiry, that our statement that what we feel now is that a care supporters bill is needed has been signed by over 80 English organisations, including, people like Age UK. I think you would have heard Caroline Abrahams use the word legal in her evidence yesterday, and that, I think, is what she was referring to.
So we is very broad when you use it.
It is.
Can I just ask, this is one of the things about patient voices for the Patients Association. So the Patients Association was part of the voluntary sector COVID-19 briefing group with DHSC, which I think was intended to be able to raise concerns from patients directly with the briefing group. Have I got that correct?
Yes.
Did the Patients Association feel like that group achieved anything?
That's probably one for the Patients Association, but I think that they felt that they didn't feel that they might have been listened to, but they might not have been acted upon. I think in one or two of the other groups that they were part of, for instance, the group that advised on communication with people who were waiting for procedures, I think they felt they had some impact there. But I think for a very clear answer, I'd have to refer you to the Patients Association, but I don't think they would be saying the things that they're saying now so strongly about patient partnership if they felt it had worked through the pandemic.
Yes. And then just finally, in terms of points of contact, you were describing earlier on when you were speaking to people in hospitals, and I think you gave 3 different examples of the type of people who you end up speaking to. When you spoke to hospitals, did you tend to find that there was one person, one role, one individual maybe who had that same level of knowledge, effectively asking it a different way? In each trust board that you spoke to, did the decisions about visiting and the application of guidance end up resting with the same position within that trust or board, or was it just spread across different people in different hospitals?
Hospital trusts vary so much. We functioned by a system of pledges, and we were able in 2018 to present pledges from all the English acute trusts to the then Chief Nursing Officer, and say, look, these trusts have pledged to welcome carers 24/7. It was a big pledge that they made, but it was entirely voluntary, and the way they would implement it was up to them. And it's also true that across Scotland, Wales and Northern Ireland, almost all trusts had made similar sort of undertakings. But because trusts are such complicated and big organisations, sometimes it would be that it was the lead dementia nurse who had made this pledge, obviously, in consultation with a director of nursing. Sometimes it would be the patient experience department. Sometimes you would find it to come from safeguarding because, it was seen to have the presence and support of a family carer is a safeguarding measure. It can be proved to reduce the number of falls, for instance, and pressure sores and malnutrition if you've got somebody there for an individual patient. So I had to think, and sometimes I would strike lucky and I would realise that we'd got a John's Campaign ambassador in that trust. Sometimes I would just have to try, and I'm afraid sometimes I just use Twitter or something to get a response and then find who I could talk to. It was by no means ideal, and that's what I mean about that. I think that every trust and institution should have a clear point of contact for the public. And, I was acting as the public.
You've given a lot of examples of the impact and what could be done better. I think in your statement you've also been keen to set out examples of things that worked well. Can you give us examples in this kind of broad area about what worked well, good practice, things that should be adopted that happened during the pandemic?
I think even looking at your evidence from the spotlight hospitals, you can see that there are some who, like I'm thinking of Altnagleven Hospital in Londonderry. You can see there's a hospital where the culture of visiting, using that word, which I try not to say visiting, but that's the word we're all using. I'm talking about therapeutic care. You can see that that's taken seriously. So in some of the hospitals that I know best, because John's Campaign has been working for a while, the culture of valuing family care and a sort of open visiting culture in non-pandemic times has really taken root, and that's true of some of the health boards in Scotland as well. So in those hospitals, because they believed in it and because they thought it was the right thing to do, they would find ways to manage it. That's the thing. Clearly, in a pandemic, you can't just go along as normal, and nobody would wish you to. But you can find positive ways round the regulations. You can find positive and safe ways to balance the risk of not caring for somebody in need and welcoming in a personal supporter.
Is this boiling down to what you were saying earlier on about trying to find a way to say yes rather than default or saying no? Yes,
indeed.
Okay. I'm going to move on to patient experience reports. If we can please have on the screen INQ 000 283957. This is at page 21, paragraph 51. I think the Patients Association provided or conducted a series of surveys. Is that correct? During the pandemic about what patients were finding their experiences? And just to pick out a couple of the highlights of this paragraph. So many people had treatments and other support postponed or cancelled. Lack of information about when services will restart. Risk of the voice and experience of patients getting lost in the need to get things done. Disabled people and people who are chronically ill have been told they've been left behind. And services for mental ill health have become even more difficult to access under lockdown. In relation to each of those points raised during the pandemic, do you have any ideas about how any of those features could be improved in the event of a future pandemic?
Yes. Some things could have been, I think, done quite simply. One of the features that comes out from those Patients Association surveys is the depression and anxiety, and indeed, well, the people who feel that they've been left behind, the people who felt that their life and health wasn't of value, those could have been alleviated in quite simple, human, relatively cost-free measures, making it important to ring somebody back, to keep them in touch with what's going on, just normal, human, positive interactions. And I can't believe that if one had thought of it that way, that there couldn't have been the man or woman power able to do that. And I think communication, such an enormous issue in every part of the pandemic, and could have been handled so much more proactively and so much more sensitively. And while we're on that, the Patients Association particularly heard from many people who'd been sent out from hospital with inadequate follow-up. Perhaps they just had a heart operation or cancer treatment, and they were hurried out of hospital back home with inadequate follow-up and very little idea who to contact. And I feel I must say that we have to recognise who it was picking up the pieces in that situation. And that was, in a vast number of cases, it was the families of those people who came home. Carers UK have drawn up a estimate that 4 to 5 million people found themselves needing to become carers. And that means carers for health, people who help somebody take their medication, help them do their exercise, help their mood stay up, try to find if there is a chance of them being referred onwards. Those people add up to 13.8 million people. And the CQC, in their State of Care report, highlighted the strain on the health and well-being of those people. And I really feel that the contribution made by those people to the continued functioning of health in our 4 countries should be recognised, and I don't think it was recognised.
And those were people who were put in that position because of decisions taken to discharge people earlier than they otherwise would if it had been in non-pandemic times. Is that
yes?
What
And people, as the ambulance services said, who were left at home sicker for longer.
If I can just come back to the communication point, and as you're saying, these basic human elements of communicating with families or patients, what do you put that lack of communication down to? Is it a lack of time of those who are on a ward or those who are treating other people? Is it a culture within NHS, HSC of not prioritising communication? Where do you think that the fix fundamentally lies?
I think during the pandemic, possibly everybody slipped into what they call command and control mode of issuing orders and indeed not encouraging alternative points of view, discussion and communication. I think that has an impact. I don't think people like being treated in that way. I think there are better ways to get the best out of people. And if a little bit more psychological insight had been used, a little bit more sensitivity in the use of language, that wouldn't have taken very much more time, and it would have been very much more productive. But I don't think the NHS is great on its communication, and I think that's a great pity, because if you're separating people and you're leaving one set of people in anxiety and ignorance, and you're leaving other people feeling frightened and abandoned, by not facilitating communication, you're exacerbating that.
Communication was a feature, I think, that flows throughout the statement. You refer to communication in the context of communication about shielding, about imposition in relation to DNA CPRs, about people feeling able to access services during the pandemic when they otherwise may put it off. Is that something that is at the heart of your experience, that difficulties with communications in many, many, many different ways across the pandemic?
And also the sort of unspoken aspects of communication. So, we can tune in our televisions and we can listen to, the people in suits telling us things, but they're not really addressing our fears, and they're not giving reassurance. And good communication, handled better, could have given us more reassurance. If you take something like the do not attempt resuscitation issue, which has been hugely covered and very well covered during this inquiry, it's not only people saying, well, of course it shouldn't have happened like that. It's the thought, if you're letting somebody you love go into a hospital where you're not going to have any contact with them and you're not going to hear anything from them, you begin to fear. You have imagination, you're human. You begin to wonder what is going to happen to the person I love in that institution. You're frightened. So the whole feeling, and I'm afraid it was a true feeling, that do not attempt resuscitation could segue into do not treat, is extremely frightening. And those sorts of fears need to be challenged, and real reassurance should be given.
If I could please put on screen INQ 000273424, page 5. This is one of the reports from the Patients Association's surveys, and these are what appears to be a similar thing they're described as principles for ensuring all patients, disabled people, carers and others are able to have the best possible experience. Do those kind of principles, do they encapsulate what it is that you're trying to convey about what you think were failings and what could be improved in the pandemic?
I think that's a really excellent list, and I feel fully in support on it. Recognise from the outset that the impact of the crisis will find hardest on those who already face discrimination and inequality. And that's a lot of people. And as Caroline Abrahams said yesterday, that includes older people, and then other people, it includes disabled people, it includes people who are already socially disadvantaged. That's a big thing. Now, knowing that, surely the Equality Act, the Human Rights Act, those laws that we already have should swing into action and say, we're a democracy, we value everybody, we're going to do something for these individuals.
Would you be able to provide a practical example of how, please feel free to choose any of those principles, or more than one should you wish, about how those principles should be brought in? In terms of the fifth one down, provide clear, concise and timely communication, updated regularly, about the impact and the crisis on support and services, what's available and how services may begin to restart. How do you think that should be done? Are you talking broadly to the population? Are you talking to individuals using the services?
I think you're talking to the individuals and their families using the services. I think reverting to yesterday, what Jackie O'Sullivan said about involving people like MenCap or the Alzheimer's Society or Age UK when you're drawing up guidance, to make sure that it's going to relate to people's actual life experiences. I think that's a sort of fundamental and sort of structural thing. I lost count of the number of times people said, I'd been ringing all day and I got no answer. The Patients Association have a horrible example, it's just one of many, about a man who spent a whole weekend ringing the hospital, his local hospital, to discover whether his wife was still alive. Let's just think of that. That was not necessary. Somebody could have answered the phone in that hospital, found the information and reassured that poor man. It's not rocket science.
Coming back to your points of communication, it sounds like it's also about NHS and HSC and others listening, not
Yes.
just broadcasting. Do you
Yes.
think there was sufficient
And
listening?
putting themselves in the shoes of the patients who are at the heart of their services. The services are there for the patients. Family carers are sometimes a way of articulating that. We heard good recommendations yesterday about how we should all do advanced care planning. Well, so somebody of my age should be doing so. I then appoint perhaps one of my children to have power of attorney for me. And that seems a good thing to do. Under the Mental Capacity Act, people would have guardianship. Under the Mental Health Act, there are people called the nearest relative. Now, all those people who had been appointed by patients to, in good times, to undertake those functions in bad times, far too many of them found themselves just rejected, just not listened to, unable to do these emergency functions which they'd accepted the responsibility to do.
Do you mean in care settings or in hospitals as well?
I mean, in hospitals. And that's why I think Mr. Wolfe yesterday was trying to raise the issue of consent to treatment, which I know your ladyship heard. For people who are not able to consent to treatment properly, I'm going to say people with dementia again, but I'm also going to say people with learning difficulty, people whose first language wasn't English, when they are taken in and they're separated from the people who have accepted responsibility for them, that's not a situation that one should tolerate, because that's then doing things to people without their consent, which is fundamentally opposed to what the National Health Service stands for. And it also inflicts great harm on the people who have said, I will stick up for you in your time of need, I will be your advocate, only to find that they're not here. It shakes people's faith in the system.
Do you think that during the pandemic, whether inadvertently or not, that there was a lack of recognition of the individual circumstances of people attending a hospital?
Can I just say a straight yes? But I won't say it about every hospital, because I do know that hospitals who had truly understood the principles of patient support and carer access did do their best. And I've heard from John's campaign ambassadors in hospitals of the way in which they did facilitate access for people when they knew that the risk of not doing so would be so damaging for their patients. And I think that, again, once a hospital is working on a positive ethical basis, that's a great strength, because we've heard too much about the distress caused to people working in hospitals and care settings because they knew that they were doing things they felt to be wrong. So if one could do better in channeling the positive principles, those hospitals, those patients will tangibly do better.
Just drawing all the threads together, apart from what we've covered so far, are there any other recommendations you'd like the Chair to consider when it comes to writing the report?
I think you've allowed me to say them. Firstly, that we play to our strengths, and that the good laws that we have and the good people, the good institutions we have within our institutions should be prioritised. I would go further than that, and I know my friends at Care Rights UK would want me to say this. We feel that actually everybody working in health and social care should, as part of their training, have an understanding of the Equality Act and Human Rights Act and the Mental Capacity Act. Those really fundamental building blocks, could be in training. We understand that that's all quite complicated, so that's why we would like the very simple right for every patient to have this legal right to a care supporter, a personal support at the times that they need it, and that should be a right with the patient. And once you establish that, then the sorts of things that went wrong with planning, because pre-pandemic planning didn't take any account of people in hospital settings with confusion. It didn't take any account of people with mental health issues in the pre-planning. It didn't take any account of visiting issues in the pre-planning. Now, once you know that your patients and your residents and your service users have this personal right which comes in with them, and they know they've got it and their families know they've got it, then you're going to have to plan a little bit differently and better, and that would improve matters. And I know I must say about involvement in patient planning. I must say that for the Patients Association, and I must say for both the Patients Association and Care Rights UK, that access to healthcare remains a fundamental equal right in our system, and you really shouldn't be saying to somebody, I'm sorry, you're living in a care home, you can't see a doctor, I'm sorry, you've got, you're old or you're disabled, this isn't going to be available to you. I must say that very strongly for patients of the future.
Thank you, Mrs. Jones. My lady, those are all the questions I have.
Thank you very much, Mr. Scott. Mr. Weatherby.
Ms Jones, I asked questions on behalf of the COVID-bereaved Families for Justice UK group. Just a short number of points from me. I want to start with shielding decisions and public health messaging, and mainly about the Patients Association surveys. So if you can't help, then obviously you'll say so, but I think you will be able to from the excellent statement that you've put into the inquiry. One of the Patient Association surveys that's covered in that statement, and for the record it's paragraph 138.1, found that 2/3 of respondents to the survey who had shielded had not been advised to do so by the NHS, and that most people had shielded on their own judgment. And it also showed that there had been low levels of satisfaction with shielding guidance, and there'd been confusion about it because of a lack of clarity. If you're able to say, does this indicate a problem with the reach of official advice about shielding during the pandemic? Or does it show a problem with public trust in that official guidance, or both?
I think it shows people's caution and people's fear, I think, and also people's wish to protect others who they love. I think that, and there's probably confusion, and I probably shared it for a bit, between voluntary self-isolation
Yes.
and shielding. I think a lot of people, particularly those who felt they had a vulnerable member of their family, did voluntary self-isolation. And perhaps that, and also people themselves who felt they had a health condition and they were frightened, chose to keep themselves out of society. And I have often thought it was a great pity that when people are looking at infection prevention and control risk factors, that somebody who had been voluntarily shielding or self-isolating, or whatever we want to call it, that wasn't taken into any sort of account if they then wished to visit or care for the person at their heart,
Yes.
if that person was taken into hospital.
Yeah.
It wasn't listened to, and I think that's a very great waste
Yes.
and a pity.
Yeah. Okay. I mean, what are the lessons going forward here? Are the lessons in terms of this issue of shielding guidance, identifying groups like yours or the Patients Association, and to liaise with them about proper guidance, what it actually means to shield or self-isolate, and better planning generally? Are those the lessons?
Well, clearly there are people who should have been consulted, and I wouldn't say it was us because we're just
Yeah.
a little campaign
Sure.
movement. But there are people, with you've had some wonderful witnesses representing clinically vulnerable groups. So of course I think those specialist people,
Yes.
should have been involved. But I think for many people, the root anxiety, and this came out in the Patients Association surveys, was their feeling of disconnection from their GP. And I worry enormously, and I'm a bit digitally challenged myself, about how our relationships with our GPs are going forward. And I listened to the gentleman from the BMA saying, no, GPs know their patients best.
Yes.
These things should come through GPs. I'm not at all sure that continues to be the case. I think it would be wonderful if everybody in our 4 countries felt they had this personal relationship with their local surgery, but I'm
Partnership.
worried about it.
Partnership.
Partnership,
Yeah, I'll come back to that if I may, my final question. Before I get there, final point on shielding. A respondent to the Patients Association survey highlighted the issue of invisible disabilities.
Yes.
Again, for the record, paragraph 142 of your statement. And that included mental health difficulties, and these invisible disabilities were being overlooked in the public health messaging and the shielding guidance. Again, it's kind of the same question, but how should these invisible disabilities have been better accounted for and supported when advice was being offered during the pandemic?
I think that should and could have been a much more sophisticated understanding of the impact of isolation on people, and I think that runs through everywhere.
Yeah.
Everything that you're talking about, and the impact of disconnection. I think perhaps we've all learned quite a lot through the pandemic about how people need each other for their identity and how people need to feel valued. If you're in a situation where people are either voluntarily or on advice withdrawing from society,
Yes.
I think it's extremely important to try and alleviate that. And people
Yes.
have mentioned some of the excellent voluntary mutual aid initiatives that sprang up, but I'll bet you they only sprang up in certain
Yes.
areas.
Okay.
I think those sorts of other ways of keeping contact, particularly for people who don't have families
Yeah.
to ring them up,
So they-
should have been prioritised.
So the guidance shouldn't have missed invisible disabilities in the first place, but it should have addressed how local groups, for example, or support networks could have been
And the
accessed.
potential for
Yeah.
those disabilities being exacerbated.
Yeah. Final point, and it's rolling back to this idea of partnership. We know, and we asked to be added to your document bundle, so I think you've probably seen it. There was a letter from Rachel Power, the Chief Executive of Patients Association, sent to Sajid Javid
Yes.
just on his appointment as Health Minister in June of 2021, so quite into the pandemic. And the whole letter was about the absence of a role for patients within the
Yes.
pandemic proposals. And Ms. Power was explaining to the new Health Minister that really the importance of partnership. And I'll just read one sentence from it. The Patients Association exists to ensure that everybody can access the health and care they need to live well. And our priority is to secure equal partnership between patients and those who deliver the care they need. Does that encapsulate what is at the heart of all of these matters? That there is a need for a recognition that healthcare must involve the patient as well as the provider in this partnership? I mean, is
And
it?
I would make it a three-way
Yes.
partnership. Oh, you knew I was going to say that. Ms. Power says it in her letter, because for some people, advocating for themselves as patients,
Yes.
some people can do it, some people can't. And that's why I really feel we need recognition for
Yes.
what I'm calling the invisible army.
Yeah, and does this letter and things like this letter, does this illustrate really that there was a lack of an equal partnership or a three-way partnership, as you put it, during the pandemic when it came to healthcare provision?
I think there always is. I think as I was saying before, it's the sick individual and the people who are worried about them, and the big institutions, and anything we can do to break down that.
Yes.
And remember that the patient is the whole purpose of the institution. We weren't there to protect the NHS. We were there to help to save individual lives,
Yes.
to protect individual people.
Thank you very much. That's very helpful.
Thank you, Mr. Weatherby. Mr. Wolfe, I think the Americans might say you're a witness.
My lady, I seem to have disappeared behind a screen, and I think I can just see you. Mrs. Jones, I just want to give you an opportunity, if you want it, to come back to a couple of topics and say a bit more if you want to. The first of it relates to people with dementia in hospital during the pandemic and their particular experience. You've touched on the position of people with dementia generally. What were the particular difficulties faced by people with dementia in hospital during the pandemic?
I think if you designed a system to make dementia worse, you would have pretty well done what happened in the pandemic. And when you think how serious an illness dementia is, I was looking up some stats the other day, and from the period from 2019 to 2022, 2023, for women, dementia was the biggest killer. In all those years, dementia remained the biggest killer, and very often it's the biggest killer for the whole of society. So dementia really matters. There is nothing you can do to cure dementia. You can only make it steady, or you can make it worse. And all those things that happen to people with dementia in hospitals were the moves from ward to ward, the people dressed in masks, the emotional temperature of the hospital. People with dementia may not be able to express themselves very clearly, but they can feel very acutely, and they can feel very aware and very frightened, but there's nothing they can do about it. And they're out of their comfort zone, and they're away from the people who relied upon to care them, and they don't understand why. I mean, how much more can one say?
What in simple terms could have been done to address those things, or perhaps was done in the best places but
Yes.
wasn't done everywhere?
Yes, thank you. No, was recognised by NHS England, was recognised at the top levels in Wales. These are people with additional needs. Was recognised in the guidance, but it wasn't implemented. And why didn't people check that it wasn't being implemented? That's what I don't understand. It's not that we just had a terrifying first month. We had 2 years, as Mr. Weatherby has just said. There were 2 years of the pandemic to make these things better. And in the good hospitals, people caring for people with dementia or learning difficulty were very often welcomed back in a careful way, to the benefit of the patients and also to the benefit of the staff, because we realise how stressed and how exhausted all staff were. So if you've got somebody says, OK, I'm going to help with this person, that's a plus. In our witness statement, we mention the case of Claire, who was caring for her father, Bruce, who had Parkinson's dementia and had a heavy fall and so had to go into hospital. And she had recently had COVID. The risk to her was negligible. She'd had the jabs, all that. And so when she was able to care for Bruce, Bruce was recovering. Then, unfortunately, while he was in hospital, he caught COVID and was then moved into a COVID area, at which point the ward door clanged shut. Claire was not allowed in, despite the fact that the risk to her, she'd been shielding, she'd had the vaccines, she'd had COVID. She was actually a medical aid worker. She was okay. She wanted to go in, but she wasn't allowed. By the time her father was eventually allowed out again, and there was a lot of muddle about infection areas, non-infection areas, it was too late for him. His Parkinson's treatment had stopped because that's a very specific treatment and it hadn't happened. His body weight had dropped. He deconditioned. Older people in hospital without stimulation decondition, and you don't get it back again. And so he just came out to die. And that was unnecessary.
And had he been properly supported, including by his daughter, how would that have helped the staff?
Well, one would like to think that the overstretched staff doing their best in those circumstances would have welcomed the assistance. With Parkinson's, for instance, you must have your medication absolutely at the right time. Now, you've got a whole ward to manage and a lot of demands upon you. If you've got somebody looking at her watch and saying, time for Dad to have his Parkinson's medication, that surely is a help. The trouble is, I think that the exclusion and the saying no sort of became institutionalised, and care did suffer, and ward staff were aware that their care was not to the standard that they wanted it to be. And in those situations, perhaps you don't want outsiders coming in, because it's just a little bit of psychology. If you're not doing very well, you don't want necessarily a loving daughter coming in and saying, what have you done to my dad? In fact, you should say, please, come in, help us with your dad. But it doesn't always work like that.
Can I ask you about a different topic, visitor guidance? So Dr. Warne, in his evidence to the inquiry, described visitor guidance as an understudied area, a misunderstood area. I imagine you don't agree with that. How could visitor guidance be improved in terms of the things about which you're concerned?
I think by differentiating between the social and the therapeutic aspects. And I'm not saying that it's not great to have visitors if you're in hospital. The great bearers, the chocolate bringers, they're lovely and they make you feel valued and they cheer you up, and that's all good, and well-being matters. So all those things matter. But I think we're talking about something very much more fundamental here, and that is what I would call therapeutic visiting. And that comes from the person who makes your life worth living. Because in hospital, you might become very discouraged, you're in pain, you wonder, is it worth carrying on? And for many people, there is somebody or some people who make life worth living, and that's why in your heart you carry on. So I think, sorry, that's a bit of a non-answer, but on a good hospital website, you will see differentiated guidance for visitors and for carers. The Department of Health has just upgraded their visitor guidance to make visiting part of the fundamental standard. But what NHS England is trying to do is establish care partner guidance and make it much more obvious why staff should welcome this person if they're willing to come. It's a voluntary role, and if the person wants them. Nobody has to have anybody they don't want.
Final topic, if I may, different sort of guidance, the end-of-life guidance. So Professor McArdle described the way in which the end-of-life guidance changed over time, including, in particular, acute periods of COVID pandemic, limiting visits in extreme circumstances, as they were called. Do you think that concept of extreme circumstances was sufficiently understood at the time?
I think it's the single most horrifying and distressing aspect of the pandemic. All the edifice of guidance and infection control was because we're all terrified of death and we want to avoid death. And then to say, and by the way, if you are dying, you're not necessarily going to have the person you love with you, or for the person outside, you're not necessarily going to be with the person who is dying. That should be an absolute right. Somebody who is dying, if it's possible, and I mean possible because their family are willing to come into possibly an infectious area, that should be an absolute right. There shouldn't be, and if it's known to be an absolute right, then you have to work out in practical terms how to facilitate it. And people are very good, if they know they've got to do something, they're very good at finding ways to do it. And that's what the good hospitals do. But it was just unacceptable. And the legacy of grief, guilt, anger, and mistrust that's left behind it is massive. And so if one could do just one single thing, it would be to say, if you are dying, you have the right to have somebody with you, and we will facilitate that, and that is our legal duty.
Thank you, Mr. Jones. Thank you, Chair.
Thank you very much, Mr. Wolf. Mr. Jones, you may have called yourself, I think, was it a little campaign group, but you obviously do excellent work for people often in dire need of support. So please take my thanks to you and to Nikki Gerard for all that you're doing. And if I may say so, you're also an excellent advocate of the cause. You've been extremely helpful, articulate and constructive, and I'm very grateful to you and to all the other people who joined in your group for all the work that you're doing.
Well, thank you for giving us the chance, because you didn't have to, and thank you very much.
Well, thank you. I just hope that it's a similar feeling to, I suspect, the long COVID groups. It's participating in this inquiry may get some recognition for the causes that you're advocating.
Thank you.
Thank you very much. I shall break now and return at 11:25.
All right.
Mr. Mills.
My lady, may I please call Nicola Ritchie, who will affirm.
Good morning, Miss Ritchie. If you would repeat after me, I do solemnly.
Can you hear us, Miss Ritchie? Are you hearing us? I think we get a message to the techies.
I can see things are happening, my lady.
presumably we did a test before.
Yes, my lady, I'm speaking to test whether we now have sound to Miss Ritchie.
Miss Ritchie, can you hear us?
Yes, I can.
Oh, you poor thing, you've been sitting there with us talking to you. And I'm so sorry, but we had, as you probably gathered, a technical hitch. If you could now just listen to the usher, please, to affirm or take the oath.
Good morning, Ms Ritchie. You're going to affirm, so if you would just repeat after me. I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth. Thank you.
Your full name, please.
Miss Nicola Ritchie.
Miss Ritchie, you have provided a statement to the inquiry. The reference is INQ 000 492258. You are a mental health physiotherapist and a member of Long COVID Physio, is that right?
That's correct, yes.
And you are here today to assist the inquiry by providing evidence of your experience of developing long COVID in the course of your work as a healthcare professional and your subsequent efforts to secure a diagnosis and treatment. Can I begin by asking you to describe your physical health before you developed long COVID?
My physical health before, I was incredibly fit. I think I was actually the fittest I've ever been in my life. I swam a mile 2-3 times a week in the mornings before I went to work. I would walk my dogs an hour and a half every day. I went to exercise classes. I went to the gym. I went hill walking. Anything I could just to be fit and active. I love to exercise. And that is something that I really miss doing now.
And again, before long COVID, what was a typical working day like for you?
A typical working day, I cover the whole hospital for around about 12 wards or so, and the wards cover inpatients covering from older adults to younger adults to brain injuries to enduring mental health and forensic patients. I would be treating them for multiple traumas, orthopaedic fractures, sore backs, mobility issues, anything and everything really. I would also see some outpatients as well. We had a number of exercise classes during the week as well, so I would be taking part in them and leading them as well.
Can you take us, please, back to April 2020 and share with the inquiry how you contracted COVID-19?
I contracted COVID-19 in the workplace. I firmly believe that I contracted it from a patient that was within the hospital. The patient was seen as being positive for COVID but untransmissible. I don't really understand why that was the case, but that was what the medical staff had told us in the hospital. He'd been positive for around about 14 days or so, but we had to see him for multiple different reasons, and it was myself and one of my colleagues that went to go and see this patient, and we both developed symptoms about a week and a half later, but we developed the symptoms on the same day, and that was the only patient that we had seen together. I feel the PPE that we were given was inadequate to be seeing patients that had COVID. It was generally the fluid-resistant face mask, gloves and a sleeveless gown is what we were wearing to go and see patients at the time. I had been face-fit tested for more appropriate masks, but because I was not carrying out aerosol-generated procedures, I was told that I was not to wear them, and that was the guidance at the time.
Had you expressed any concern about seeing a patient presenting with COVID-19 with only the PPE that you have described?
Of course. I felt that we should have been wearing more appropriate PPE regardless of who we were seeing. At the time, COVID was so unknown. It was quite a scary time to be working because nobody knew what to expect and nobody knew what was going to happen. There were so many people dying all over the world. That was not something that I wanted to be exposing myself to.
Can you describe the symptoms you began to experience?
I started off with a cough, but the cough didn't last particularly long. It was only over a couple of days I had the cough, but I experienced temperatures. The temperature lasted possibly a week or so, but it was mainly the fatigue. I was extremely fatigued. I was sleeping pretty much the majority of the day, only awake for maybe an hour or two in the day. I tried to do anything at all, get up, get washed, even put a load of washing on, and I was completely and utterly exhausted from it. I had a very bad shortness of breath from doing anything at all, and I had a lot of pain. I'd never experienced back pain in my life, but for some reason, my back had become very painful, and I couldn't understand why.
Were you self-isolating during this time? How long did you self-isolate for?
I isolated for 2 weeks. That was the recommended time to take off at the time. So I isolated for the 2 weeks.
And during the 2 weeks, did your symptoms improve or did they become worse?
They became worse and then better. So worse over the few days that I first contracted it, and then gradually better. But I wouldn't say better to the point that I was functioning. I felt after the end of the 2 weeks that I'd never really taken time off work, so being off was really alien to me. I felt that if I pushed myself to get back, then I would get better faster. But that was, in hindsight, that's a very silly thing to do. But I feel like if I did push myself, I would be able to get back into a routine, get back to normal a little bit faster. But it took me quite a number of months then to be able to do anything that I would have done normally.
We'll come in a moment to look at the extent to which you're able to carry out your regular duties when you return to work. But can I ask this before we move on? During the 2 weeks you were self-isolating, were you able to access a test for COVID-19?
No. There was an online application system within the NHS trust that I work for, and I applied for a test at the time, but I never actually heard anything back from it. At the time, I was told, word of mouth, that there were maybe possibly 20 tests being carried out every day at that point. So I imagine, there would have been hundreds of tests needing to be carried out every day.
When you return to work, and you've told us about the routine of your working day before this time, to what extent were you able to carry out those regular duties?
I was back to working my full-time days, but I was very much unable to carry out my full duties. Because of the fatigue and the shortness of breath and the discomfort, the pain that I was in, I really struggled to carry out any exercise as such, or any of the moving and handling, any of the more difficult moving and handling that I would have to do. I had to do a lot of online learning. I had to do a lot of lighter duties. I couldn't do all of my duties at that point.
You say in your statement, and I'm at paragraph 29, that the muscle pain you had during the acute stage developed into severe back pain.
Yeah. And as a physiotherapist, I thought, I know how to treat this. I'll use all of the tools in my toolkit that I've been teaching everyone all of these years. And no matter what I did, it only got worse. I did an assessment on myself. I carried that out. I thought these are the exercises that would generally help back pain like this. And literally everything I did made it worse. The only thing that actually helped was when I had a bug, like a very bad bug, a few weeks down the line. And I was basically bedbound for another couple of days. And that helped to ease my pain, which goes against everything we would ever say as a physio. Don't go to bed and rest because that's not going to help your back. But that was the only thing that helped me.
Moving, please, to September 2020. You describe in your statement, and these are your words, suffering a severe crash in September 2020. Can you explain, please, what happened to you, and perhaps also what you mean by that term, crash?
Well, I would say that between April 2020 and September 2020, I pushed myself as much as I possibly could within my limits to get back to fitness, to get back to what I would normally be doing. In hindsight, again, after hearing many other people's stories of similar experiences, it's probably the last thing I should have been doing, but all I wanted to do was get back to some sort of normality. For maybe 4 to 6 weeks over the summer, I was able to do a little bit more of my normal kind of exercise. I went hill walking again. I was enjoying walking the dogs. Then September came and all of the original symptoms of COVID came back. I thought I was positive again, but on testing, I wasn't. I think it's because I pushed myself too much and my body then responded very negatively. And I have never recovered since. That is why I call it my crash, because I crashed and I've never recovered from it. Sorry.
Take a breath, Ms. Ritchie.
Yeah. Sorry, I'll just take a quick drink. My original symptoms that I had carried on. The breathlessness, the pain. The pain came back just as bad as it had done the first time around. The lack of ability to exercise. For example, if I was, I took the 2 weeks off work as usual. I thought, right, I'll get back to work as normal. But when I got back, even basic things like very, very gentle exercise, if I was doing anything like, say, a push-up against the wall, I would be sore for a week. All of the muscles that were involved in that exercise would give me pain for a week and I would be struggling to move. That has basically led to me not being able to exercise. If I do any kind of exercise now, that is the kind of thing that will happen to me. I went back to work and was on even lighter duties than I had been the first time around.
Around this time, did you become aware of the term long COVID?
I think it would have been around about the December. I heard about it in the news, and I did a little bit of research into it, and so many of the symptoms resonated with what I'd been experiencing. I didn't have a clue what it was, but I've been on quite a learning experience since.
Can I ask this? Did you discuss the possibility of you having long COVID with your GP?
I did. I phoned the GP, I think it was in the December, and I said, I feel like I may have long COVID. They asked me why. I explained the symptoms I'd been experiencing, and it was never questioned. No differential diagnosis was ever chased, no testing was carried out. They just took my word for it that I had long COVID.
At your paragraph 33, you say this: I spoke to my GP. My GP responded that there was nothing they could do and I should look online for resources.
This is something that I have heard continually from my GP basically since. I have had multiple contacts with the GP to the point that I've stopped contacting them, because every time I did, it was a case of, there are online resources, there's nothing that we can do. Go and have a look online, it's for self-management only.
I think around this time, in December 2020, you also found out you were pregnant.
Yes.
Can I ask this? Did being pregnant have a noticeable effect on the long COVID symptoms you were experiencing?
Massively so. Basically, from day one of being pregnant, I couldn't understand why I was suffering from debilitating fatigue. Like, I'd never experienced anything like it in my life. I had gone into work and I tried to push through it, but after maybe a week or so of trying to really push myself through that, I had to basically end up going off sick because I was struggling so much. I was going home and not functioning. I wasn't able to do anything on my days off. It was so challenging.
As we move into the new year, in January 2021, I think you joined Long COVID Physio, is that right?
Yes.
Can you tell us a little bit about how you found out about that organisation and what help being a part of it has offered you?
I think I heard about it. It was a webinar on long COVID that one of the main people within long COVID physio had been providing to give a little bit of education for people. So I had a look online and found out that it would be quite a fantastic thing for myself. It's mainly, I joined it for peer support. At the time, there were only a few of us that were members of long COVID physio. And what was fantastic about it was we could ask all of the bizarre symptoms. There's so many symptoms that long COVID has, but none of it made sense at the beginning, and we couldn't figure out what was going on. So we kept almost like a back and forth with each other just to find out, are you experiencing the same as this? What does this mean? And we all kind of figured it out together. It was fantastic.
You say in your statement that the more people that joined the group, the more information there was.
Yeah. And that was key, because the more people, the more knowledge. And it was eye-opening for me, because so many people had so many good hints and tips of different things that you could try and help yourself to get better. And I was willing to try anything.
At your paragraph 39, you say, in July 2021, I was finally provided with a diagnosis of long COVID from a consultant at my local hospital. How did that diagnosis come about?
I basically went to my doctor and said, if you can't help me, please send me somewhere that can. So they sent me to, it was just like a general department within the local hospital. I had been asking my GP for a number of months to put long COVID or something COVID related on my footnotes for work, because I wasn't going to be getting any sick pay for being off. From the 6-month mark, I would have been down to half pay or no pay. But with that COVID diagnosis on my footnote, I would have been able to get COVID special pay, which was quite important at the time. So I basically had to go to that department to get a diagnosis.
Having first contracted COVID-19 in April 2020, then suffered your crash in September 2020. How did you feel in July 2021 when you received your diagnosis of long COVID?
At the point it was means to an end, I knew I had long COVID. It was a case of, and it's a bit of validation that someone actually believes me, but at the same time, they turned around and said to me, what are you actually expecting from being here? Because there's nothing we can do. So it was a good thing that I had the diagnosis, but on the other hand, there was nothing that they could do to offer me to help. So I was still left in limbo.
In September 2021, you gave birth to your daughter, and I think within a month or so, you had contracted COVID-19 again, is that right? On that occasion, were you admitted to hospital?
Yes.
How long were you in hospital for?
I was in for 4 nights.
Can you describe the symptoms you experienced during that infection and the treatment you received, please?
During that infection, it was mainly the debilitating headaches that I struggled with more than anything. I had the fatigue, I had the fever, all of the usual things, but it was the headaches. I had incredibly bad light sensitivity, so I was basically sitting in the dark for days in the house. I was unable to eat because of nausea. I was unable to drink because of the nausea. So I was admitted basically because I was so dehydrated. My oxygen saturation levels were low, so I required supplementary oxygen when I went into hospital. I had to be put on a drip because I was so dehydrated. Yeah, it was not a fun time.
Can I ask you now, please, about the treatment that you have been able to obtain for long COVID? In your statement from your paragraph 43, you set out the private treatment that you have sought. Can you tell us a little bit about that, please?
In March 2023, I had basically had enough. I had been fighting, trying to get some form of treatment from the NHS since probably from the December 2020. And I kept getting knocked back every time. But I was researching everything that I possibly could to help myself. I eventually found out there was a private GP seeing patients with long COVID. So I thought, I've got nothing to lose, I will go on the waiting list. At the time, it was a video call that I had, thankfully, because the clinic was in Stirling, which was quite a long way away. But this was the clinic that pretty much most Scottish people with long COVID have gone to at some point. It was one of the most validating experiences I think I've ever had. She believed everything I said. I didn't have to fight to get my point across. I told her the symptoms I was experiencing, and she diagnosed me and offered medications to try and help my symptoms. It was a massive relief to be heard.
Did the medications help?
They have to an extent, in terms of I have managed to stabilise my symptoms, so I don't have bad crashes as much anymore. My headaches have been helped massively, things like that. But I still am operating at a very low level. My fatigue, my brain fog, everything like that is still at a very low level that I struggle to function day to day, but I don't experience the ups and downs that I did before, which is a massive improvement for me.
You have also attended a long COVID practitioner service.
Yes.
What did that service offer you?
It's mainly run by other allied health professionals, which is fantastic for anyone that's in that initial stages of recovery, because they can teach all of the pacing advice and lots of the education of things that you can do to try and help yourself to self-manage in that initial stages. But because I'd been going through it for almost 4 years by that point, I had followed all of that advice, and I had managed to get my pacing down incredibly well. This is the sort of thing that I teach to patients on a day-to-day basis in my work. So if I don't follow it, I'm kind of a hypocrite, really. So I knew exactly what I should be doing. And everything that they went through with me was just reinforcing that I was doing the correct things. I did ask for a medication review because I'd been on the medications that the private GP had prescribed to me for about a year. And I said that I think it's about time we had a review just to see if there's anything that needs to be changed with them or anything along that lines. So I had an appointment with the consultant within the practitioner service. And I was told that basically all of the medications that I had been prescribed, there was no evidence behind them, so I shouldn't be on them. So I was a bit deflated with that. It was quite difficult.
Can I move to our final topic, please? The impact of long COVID on both your physical and mental health. You have, throughout your evidence, described the symptoms you have suffered through 2020, 2021. Can I ask, please, for you to describe your current persistent long COVID symptoms?
At the moment, I have symptoms of POTS, or orthostatic intolerance. So basically, when I stand up, when I go from lying to standing or sitting to standing, my heart rate elevates quite significantly. If I do any kind of exercise, as in maybe 20 or 30 seconds worth of very basic exercise with patients, my whole body feels like a lead weight, and I can feel palpitations. My heart is incredibly fast. I get short of breath very, very easily. And I still experience incredibly debilitating fatigue. Throughout the conversation today, I've obviously been struggling with a lot of brain fog. Word finding difficulty is one of my big ones. Even just basic, easy words. It took me about 12 hours to think of one word yesterday. I was texting a friend to try and find out this one word, but I could not think of it for the life of me. I had about 5 different ways to explain one simple word, but I could not think of that one word. But that's just day to day for me now. I'm trying to think of other symptoms that I experience. Basically, I have to use a mobility scooter because I can't walk any length of any distance at all. If I try and walk any kind of distance, I really struggle. The post-exertional malaise is awful. I think I have around about a 2,000 step limit every day, and that includes walking around the house, like going back and forth to different rooms and things like that. So that is my maximum, really. I normally try and stay around about the 1,000 limit, and that's kind of more comfortable for me. But anything over 2,000, I know I'm going to struggle the next day or later on that day.
In your statement, you use the term energy spoons. Can you describe to us how that helps you manage your energy?
Every day I have to pace to within an inch of my life. So everything I do is planned. I can do one thing a day, whether that is going to an appointment, taking my daughter to a 30-minute swimming lesson, or meeting a friend for coffee. I have to basically think of everything I have to do within that day, and I have I have a certain amount of energy for that day that I can use, and I have to pace it through that day. I think of things almost like as if I get up, if I have a shower, that's 1 spoon for the day. I have, say, maybe 10 spoons for the entire day. Washing is 1 spoon. Having breakfast is another. Drying my hair, that generally takes 2 spoons because it doesn't happen that often because it is so exhausting. Things like that. If I have to do anything within the day, that has to be allotted to a certain length, like certain amount of energy, and I have to make sure that I don't go over that allocation of energy spoons.
What has been the impact of developing long COVID on your career?
It has been massive. I feel like I am at risk of losing my career. I have been fighting since I got back to work to try and stay within my career because it's something that I am passionate about. It's a job that I love. I love treating people. I love helping people. But because of what has happened to me with long COVID and the symptoms that I struggle with every day, since I've been back, I've had to reduce my hours even more. So I was previously full-time. Now I'm down to 18 hours a week. But even that is still a struggle. I'm on restricted duties, or not restricted duties. I've got reasonable adjustments. So I have a mobility scooter to get between wards. At the moment, I don't have to participate in the exercise classes because of the impact that they have on me. It's quite scary, really, because I don't want to lose my career. Although being in the workplace for me at the moment is still a terrifying place because of the risk of contracting COVID. I still want to be there. I still want to help people. I still want to be able to fulfill my role. That is something that I'm really passionate about and something that I still want to continue to do, but I can only do that if the reasonable adjustments are continued longer term.
Finally, this, please. Can you help the inquiry understand how long COVID has affected the way you are able to interact with your daughter?
It has been very challenging. She is my only daughter, and since she was born, I have really struggled with such fatigue. When she was born, I couldn't stand up and hold her because of the effort involved. I couldn't walk around the room with her. I still can't carry her and walk because I become so incredibly breathless and fatigued straight away. If I go to the park, someone else has to be with me because I can't run after her. If we do anything along that lines, basically someone else has to be there because, she is full of energy and I can't match that. It's so difficult. We spend quite a lot of time doing things in the house, like different toys and games and things like that in the house because it saves my energy, which is so incredibly difficult because all I want to do is run around the park and play with her. But I have to make sure that I can do as much as I can with her for the rest of the day. And if I do too much at one point of the day, I'm going to be useless the rest of the day and not be able to care for her.
Ms. Ritchie, thank you. My lady, that's all I ask.
Ms. Ritchie, thank you very much indeed. I'm really grateful to you for your help. I can't imagine how difficult it is to manage the symptoms you describe and a 3-year-old. Is she a bit of a terror?
She very much is.
It doesn't surprise me, having had grandchildren recently at that age. But thank you so much. I do hope your symptoms improve. I hope your career does thrive when they do improve, and I hope the relationships with the family get much better as you get better. So thank you for all your help.
Thank you.
My lady, next, may I please call Professor Chris Breitling and Dr. Rachel Evans, who will both affirm.
Thank you.
Sincerely and truly.
Sincerely and truly.
Declare and affirm.
Declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Sit down. If you repeat after me. I do solemnly.
I do solemnly.
Sincerely and truly.
Sincerely and truly.
Declare and affirm.
Declare and affirm.
The evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Sit down.
Hope you haven't been waiting for too long. I think you did arrive quite early, so I'm sorry if we've kept you waiting.
Not at all.
Your full names, please, perhaps starting with you, Professor.
So Professor Christopher Breitling.
Professor Rachel Evans.
I'm so sorry, Professor Evans. I introduced you as Dr. Evans.
That's fine.
I think you introduced both of them as doctors, actually.
Did I? You have...
Nothing wrong with that.
You have professors both provided a report to this module of the inquiry. For reference, that is INQ 000 421758. And it's right, isn't it? You also prepared a report and gave evidence to Module 2.
That's correct.
Can I begin with a very brief summary of your experience? Professor Breitling, you are a professor of respiratory medicine at the University of Leicester, and you have been a treating consultant physician since 2004.
That's correct.
Professor Evans, you are an associate professor at the University of Leicester and an honorary respiratory consultant physician at the Glenfield Hospital, which is part of the University Hospitals of Leicester NHS Trust.
Correct.
Since 2020, both of you have been involved in studying long COVID and treating those with it.
That's correct.
Now, I know that you have divided areas of the report between the two of you. We'll adopt the same format as when you last gave evidence, with whoever took the lead on a particular issue providing the answer. Can we begin, please, by setting out the central pillars of our current understanding of long COVID? First, the definition. Please, can we go to INQ 000 238545? This is an extract from NICE's Managing the Long-Term Effects of COVID-19. And we have here under post-COVID-19 syndrome this: signs and symptoms that develop during or after an infection consistent with COVID-19 continue for more than 12 weeks and are not explained by an alternative diagnosis. It usually presents with clusters of symptoms, often overlapping, which can fluctuate and change over time and can affect any system in the body. Post-COVID-19 syndrome may be considered before 12 weeks, while the possibility of an alternative underlying disease is also being assessed. Is this the definition according to which long COVID is diagnosed?
Yes.
Can you help? When did NICE establish this definition?
That was towards the end of 2020. But the patient-derived long COVID term happened much earlier.
Quite. And we see here, don't we, post-COVID-19 syndrome. Is that a term you use, or do you use the long COVID term instead?
I and our clinic use the long COVID term.
Can you help the inquiry understand why that is?
Because it was developed for a reason. It was developed by the people that were experiencing this, and they chose the language very carefully. They describe in their report their concerns around the post-COVID-19 syndrome, and I think it's very helpful that we all use the same language and that we are a group together. We don't want language to become divisive between patients and healthcare professionals and researchers. And there wasn't any new science that led to that definition. I think that would be a different scenario, but I think any terms going forward need to be jointly agreed by all the stakeholders.
If we can just return to the NICE page here, the paragraph below the one we've just read together says this: in addition to the clinical case definitions, the term long COVID is commonly used to describe signs and symptoms that continue or develop after acute COVID-19. It includes both ongoing symptomatic COVID-19 from 4 to 12 weeks and post-COVID-19 syndrome, 12 weeks or more. Do you find this use of the phrase or the term long COVID a helpful one or not?
I think so. I think it's the term that most people understand and understand what is being described, both patients and healthcare professionals and researchers, and now the media.
Next, please, this. The inquiry has heard Professor Whitty use the phrase, if you don't get COVID, you don't get long COVID. But what, if anything, does the severity of someone's acute COVID infection tell us about A, the likelihood that they will develop long COVID, or B, if they do, how severe their long COVID symptoms will be?
Okay, I'm going to answer that question in two parts because it is quite nuanced. If we're talking about cohorts of people, there's a greater likelihood of getting long COVID if you have a more severe acute infection. And in a cohort, there would be more chance of having severe ongoing sequelae long COVID, according to how severe the infection is. However, it's really important for everyone to understand that somebody can have a very mild infection, in fact, sometimes even be asymptomatic, and still get long COVID and have very severe long COVID.
You say it's really important for everyone to understand that. Do you say that because there is evidence, anecdotally perhaps or otherwise, that for a time was not understood?
I think that's correct. In the first few months of the pandemic, and actually people with the lived experience of not being hospitalised and developing long COVID very clearly articulate this issue, that the post-COVID sequelae and long COVID was mainly to begin with studied and clinical care directed towards the awful illness that people were experiencing where they were hospitalised with severe lung injury, and healthcare and focus was very concentrated on that, as it should have been, but there should have been more understanding, research and clinical care looking into those that were developing it in the community.
Next, can we think about someone's characteristics? Are we able to identify the characteristics that increase the chances of someone developing long COVID?
Yeah, absolutely. The scientific evidence now is very strong, but again, I give the answer in two parts, that there are risk factors for getting long COVID. So we've already discussed one, the severity of the acute illness, being around middle age, being female, having a higher body mass index, somebody with pre-existing, coexisting conditions, and those from lower socioeconomic status, all have been shown consistently in many research studies to have a higher likelihood of getting long COVID. But I think there has been a new definition of long COVID this year that was published in one of the very high impact medical journals. And I think one of the most helpful thing that that statement made was that anyone is at risk of getting long COVID, and that is absolutely true, from children to older adults, across different sexes, gender, different geography, different socioeconomic status. Everybody is at risk if you've had COVID.
Do the same characteristics that you listed in your answer increase the chances of someone developing a more severe form of long COVID as well?
Yes, and again, this was shown early on from the research studies that again, people of middle age, females, higher body mass index were more and more pre-existing long-term conditions were more likely to get severe long COVID.
Is there evidence that healthcare workers as a cohort were at a higher risk of developing long COVID during the pandemic?
In relation to the fact that they were higher risk of contracting COVID-19 during 2020, and certainly during that lockdown period where everyone else was isolated, they were much higher risk of developing COVID-19 and therefore higher risk of developing long COVID. And particularly in that time, just to take us all back, there were no vaccinations. So for most of 2020, if you were contracting COVID-19, it was the wild type virus and pre-vaccination. So a much higher chance of developing long COVID than now.
Next, some figures, please. Approximately how many people in the UK are currently suffering with long COVID?
Caveat to what I'm about to say, which I know we're going to come on to at other points, is around data and the diagnosis of long COVID on healthcare records. Our best UK data comes from the Office of National Statistics, and they published another report earlier this year showing an estimated 2 million people are still living with long COVID. And some really important statistics, so that's the same number as we had in 2023, so 2 million. Some important statistics to highlight on that would be at least 1 million of those have been living with this, as we heard from Nicola, this very difficult illness for at least 2 years. So that's clearly showing that for a large proportion of people, it's not going away. There are some people that have recovered, but there were also at least, I think it was 500,000 that had developed that since 2023. So there were new cases. And a question that I'm often asked is, well, is it just a problem from 2020, or are you still seeing new cases in the clinic? And very tragically, we are still seeing new cases in the clinic, and the ONS data highlight that.
To put those figures into perspective, are you able to give examples of other chronic illnesses that have a similar prevalence?
Absolutely. So both Chris and I in clinical care, we're lung doctors, and we look after people with chronic lung disease, and one chronic lung disease called COPD. There's at least 1 million people in the UK living with that condition, and probably many more where it's not been diagnosed. Heart failure, very common long-term condition where the heart's not working properly, at least 1 million of those. So even just combining our commonest chronic or long-term heart and lung conditions is very similar to the prevalence that we're seeing of long COVID.
With that context, are you able to comment on the scepticism that those suffering from long COVID have faced when seeking a diagnosis?
Yeah, it's heartbreaking to hear, but you heard from Nicola, her experience as a healthcare professional, and the qualitative studies where people living with this illness have been interviewed, and there's been many of them now, so it's not just one or two anecdotes, sadly, that people have faced scepticism both in the public and through their healthcare contacts.
Can I just ask, I'm sorry, but finish your answer and then I'll ask a question for me.
And I was just going to add, and that's deeply unscientific.
Well, that may lead into my question. I think I've been told maybe by you in the past that it's well known for a virus to have sequelae. Therefore, why would medical health professionals not be ready for long COVID, if you see what I mean?
Yeah, and I think it's a really important question that actually this whole area has been under-researched and under-invested for clinical care for decades. But you're right, the post-viral syndromes are well known about, and there are experts in that area.
If I may add to that, I mean, you're absolutely right that people should have been prepared. So one of the first things that we and other colleagues did very early on in the pandemic is highlight that it was quite likely that there would be consequences that then were sustained after the acute infection. And that was very much the driver for us to then seek early research funding. So I think it was clear, but it didn't seem to have the same priority early on. And the scepticism that you were asking about is clearly unfounded. Not only have we heard testimony today, and many people in this room could also give similar stories, we know from the epidemiology studies, when you actually look at people who were studied before the pandemic, during and after acute infection, that there was a step up in symptoms in those who had COVID infection compared to those who did not. We know from imaging studies that there is organ damage in a number of patients. This is done by multi-organ magnetic resonance imaging. And we know from a number of blood tests that there is evidence of changes in the blood, in particular around inflammation. So there is overwhelming evidence that there's a change in symptoms, organ damage and inflammation.
Can I now ask you about symptoms? Approximately how many symptoms of long COVID have been identified?
Well, well over 200 is, I think, the largest number I've seen, but I expect it's even larger than that, and experienced in very many different ways and wide-ranging, which is extremely challenging for the person experiencing it, but does give a challenge to healthcare professionals and healthcare symptoms as well. And although there are over 200 symptoms reported, there are some that are particularly common, shall we say, and fatigue, breathlessness. We heard from Nicola about that back pain and pain that she'd never experienced before, difficulties sleeping. There's a sort of cluster of quite common symptoms, and certainly as a healthcare professional now, wherever somebody is working, they should absolutely be alert to those symptoms and understand that that is really classic for long COVID. And whilst in those definitions, it's really important to exclude other conditions that may either be contributing or causing the symptoms, we can diagnose long COVID as what we would call a positive diagnosis, i.e. a clinical diagnosis because of the clinical scenario that it's captured in, rather than we would like to have a biomarker that tells us it's this disease, but at the moment clinicians can make a positive diagnosis of long COVID from the symptoms and the context of the illness.
what do we know about the persistence of those symptoms?
So for any individual, it can be quite different. For most people with long COVID, in that first, or maybe it's not most, but there's certainly different groups of people within long COVID. So there is a group, thankfully, that do get the symptoms that do seem to recover within that first year. We see that clinically, the ONS data highlights it, and other studies have highlighted that. But then there is this very large group where the symptoms, if they've gone beyond a year, seem very persistent, and certainly Nicola described the after effect of that. And Nicola also described that it wasn't this sort of linear trajectory. Now that can be the case for some people, that they develop terrible symptoms at the time of the illness and then over the years they seem to improve a small amount. Other people really develop this waxing and waning of symptoms, and that's very challenging to live with. And again, others here would be able to describe that better than me, but the planning that you don't know how you're going to be one day to the next, very difficult.
Was the crash that Miss Ritchie described something you recognised?
Yeah, so we hear about this in clinical care. Now, Nicola's was very obvious to her what had happened, but actually many people aren't quite so alert or knowing what's happened. So, and that was, she describes that sort of episode in September, wasn't it, where everything just became awful again. Some people will describe those crashes depending on what they've done the day before or the day itself, and they can happen very frequently for some people, and actually probably for many people with long COVID, they develop something that we term post-exertional symptom exacerbation that can occur sort of 12 to 24 hours and last many, many days after a particular activity, and that activity doesn't have to just be a physical activity. It could be concentration, it could be emotion.
Professor Breitling may have already touched on this, but what can you tell us about the mechanisms of long COVID, that is, the bodily processes by which long COVID physically causes the symptoms we have discussed?
So we've learnt a lot over the first few years since the beginning of the pandemic, and no doubt there's much more to learn. We recognise that in some patients there's evidence of viral persistence. We don't fully understand how common that is. We can measure changes in the immune system, so we now know what type of cells are activated, what pathways in the immune system are activated, and these all open up potential targets for therapies. We recognise that the lining of the blood vessels, the endothelium, is activated, and there's change in organ damage in the brain and other organs. And we also know that the nervous system that controls blood pressure, temperature control, the autonomic nervous system, can also be disrupted. And we know, as Rachel's already alluded to, that there are a number of risk factors. So those risk factors, such as things like changes in your metabolic profile, whether that may be increased weight and obesity as an example, are things that also amplify your risk of then having long COVID and can also be potential treatment targets.
New topic, please. Access to healthcare and treatment for adults with long COVID. Starting in England, please, with the Your COVID Recovery website. That website was perhaps, until it closed earlier this year, the first port of call for many people seeking help with long COVID. In respect of the information it provided about long COVID, can you help us with what the purpose of the website was and whether, in your view, it achieved its aims?
Yeah, so the website was developed early in the pandemic. So it started in May 2020. It was formally released in early July 2020. And the main purpose of the website, Nicola talked about self-management. Nicola's a physiotherapist and clearly very aware of what self-management is, whereas a lot of people wouldn't necessarily know how to support their own self-management. And because the consequences of having Covid-19 are very varied, the website was really designed as a light touch information sharing platform and really aimed at those probably at the milder end of the long Covid spectrum. It was originally designed mainly to support people post-hospital so that they had some information about the symptoms as they left hospital and continued to recover, hence the name. What it wasn't set up to do and what it never could do was provide complex management advice for somebody like Nicola that we heard, where she had very complex symptoms, a very severe impact, where you really need healthcare professionals and to work with you one-to-one.
Next, long COVID clinics. An introduction to them, please, if you would. How does someone access them, and what do they offer to an individual with long COVID?
Okay. So the long COVID clinics in England started really through the post-hospital route and originally were set up on the ground by respiratory lung teams trying to support the people that were coming out of the hospital after having that lung injury. The NHS England came together to develop a task force in October 2020, and quite a few of those clinics that had already started were then part of the 70 clinics that were funded from 2020. As far as accessing them and what they should provide, there is an NHS England service specification, very much advocating a tiered approach. So depending on the needs of the individual, the healthcare request should match it. So for milder long COVID, sometimes self-management support, the use of a website, online platforms may be appropriate. For people with much more complex needs, there really should be available people with healthcare professionals with expertise in long COVID, a multidisciplinary team, meaning doctors, nurses, occupational therapists, physiotherapists. That's not all-encompassing. There are many different healthcare professionals that we need. And also a key bit is it needs to be interspeciality. We heard that there are 200 plus symptoms. We cannot and mustn't send poor individual people to 200 different specialists. For those symptoms that I mentioned, if we think about pain, you might need to see a rheumatologist, problems with memory, problems with concentration, may need to see a neurologist. Chest pain, you might get sent to a cardiologist, breathlessness gets sent to a lung physician, and it goes on and on. So these long COVID clinics must have a meeting where you've got the expertise of all these different professionals. Certainly in our clinic and in some others, we do this with a virtual team meeting. So the individual person with long COVID comes to see an individual clinician. That's the partnership, and then you bring in that extra expertise that you need through virtual meetings, and so that we're not sending people for multiple appointments.
The 70 clinics that were in place by, I think you said, the end of 2020, is it possible to say how many of those are operating now?
Yeah, so the number increased to 100 at some point. I think that was in 2021, the peak. I don't know the exact number now because the long COVID task force has finished. But I do know that some have very sadly stopped altogether. Others have got embedded within the integrated care systems, within care for other long-term conditions. And there probably are few that are really running as the NHS England service specification suggests.
Generally speaking, would someone be referred to a long COVID clinic via their GP?
Yes, which is the same route to specialist care for any long-term condition. And there usually are multiple things that GPs and primary care can help with and should help with first, and then refer on to the specialist as needed.
I wonder if we could have on screen, please, INQ 000 492271. These are the results of a survey conducted by the Royal College of General Practitioners between August and September 2020. In response to question 8, we find that 51% were not very and 14% not at all confident in treating patients with long COVID symptoms at that time. Do these results to you suggest that in those early stages of long COVID clinics, the end of 2020, there may have been a lack of uniformity in the approach of GPs to making referrals to those clinics?
Yes, and I think we've heard that in the experience of people living with this condition. And I think it's very challenging for primary care. You know, they have a huge amount that they're expected to do. I think that 65% that were not feeling confident, we need to absolute support. And I think that's where some of the issues that people have described accessing healthcare and sometimes hearing the scepticism about what they actually have. If people are not aware of long COVID and not aware how to treat it, you can see how that happens. And then absolutely, if you're not aware of a condition and you're not aware of what support there is, then the referrals won't happen basically. And there's also a responsibility of those working in the long COVID services to, one of the key things of why also you would want a long COVID specialist and clinic is so that you can outreach and help and support primary care and make your service well known.
That certainly sounds like a recommendation for how a more consistent approach to referrals might be achieved. Is there anything else you would like to see to ensure a consistent approach to referrals?
I can't think off the top of my head, sorry.
Not at all. Is patient self-referral an option to consider here?
I think the healthcare service needs to start thinking about this for all long-term conditions. But as I said, primary care really do have a valuable role. And I suppose I would not want to see that missed, because actually then other problems can happen, because there are things that primary care do really well that specialists don't. When you hear how difficult certain people have found it to access healthcare, you can understand, and specialist care, why they are advocating. If I know I've got long COVID and if primary care feel that they can't do any more for me, I want to be able to access the specialist clinic. But I think we would have to be very careful on how that was implemented in future. Needs a lot of thought and really working closely with both people living with the condition, healthcare professionals, and the organisations.
At your paragraph 78, you refer to NHS England providing funding to primary care for the long COVID enhanced service. Could you tell us a little bit about that, please?
Yes, it was supposed to really be to develop long COVID champions, to really do that role I was discussing, where you've got a link with a long COVID specialist service, but also then can upskill and promote the long COVID service within primary care, and also ensure that on the ground GPs are trained in this new condition so that they know about it and know how to refer.
Are you able to comment on the extent to which that has been a success?
I don't think we have that data to know exactly what we know, that whether GPs accessed it and there were a few criteria that they had to check, but I don't think we really know the impact of that.
My lady, I'm about to move on to a new topic. I wonder whether that might be lunch.
Certainly. I shall return. You remember that we have breaks. We'll certainly have a lunch break, as you'd expect. So I shall return at 20 to 2.